Good morning, everyone. I'm Paquita Jarman-Smith from the State Education Resource Center. I'm welcoming you to day 2 of our virtual summit of strategies for schools in substance misuse prevention and supports. I'm here with my colleague, Lauren Johns, and I am going to go through some logistics before we introduce our presenter today. The session title is Adolescent SBIRT, Adolescent Girls and Opioids. This event can be shared in your social media using hashtag CT Prevention. Share some highlights of what you're learning today in this breakout. We are sharing our evaluation link, which is so important. Please make sure that you complete the evaluation. Let us know what you learned. And when we get started, I will put a link to all of the handouts and resources for you. So today I'm going to introduce Aisha Hamid, the program manager of the Connecticut Clearinghouse at Wheeler Clinic. She's going to be our speaker, so let us welcome her at this time.
Good morning, everyone.
Good morning.
I'm going to bring up my PowerPoint. Okay. Can I share the screen now?
Yes,
okay.
You can.
Okay, good. Okay. So again, my name is Aisha Hamid. I'm program manager at Connecticut Clearinghouse. Clearinghouse is a program of Wheeler Clinic, and we are funded by Department of Mental Health and Addiction Services. So this is some housekeeping. If you have any questions, how are they asking the questions? Is it the chat function or Q&A?
You can put it in the chat function as you come up with questions, and we're going to save some time at the end of the presentation, 5 or 10 minutes, so that you can ask your questions.
Great.
And everyone is muted, so
okay, great.
We can save those for the end.
Okay, so Connecticut Clearinghouse is a library and resource center, and resources and materials, they are specific to substance use prevention, mental health, treatment, recovery, health promotion, wellness, and many other related topics. For more information, you can visit our website, ctclearinghouse.org. You can call us. We are taking mail orders, and we are also offering curbside pickup by appointment. Just to let you know, the curriculum, Adolescent SBIRT, it is developed by Dr. Sharon Levy from Boston Children's Hospital. We received funding from U.S. Department of Health and Human Services Office on Women's Health, and it was a requirement to create a supplement on adolescent girls, their unique risk factors in use of opioids. So that is the supplement that is developed by Wheeler Clinic. But want to let you know that you can use this protocol with all adolescents, whether girls or boys between the ages of 12 to 18. The goal of this grant was to provide, it's a 3-year grant, it ended in June. We have received a no-cost extension because we weren't able to provide any trainings between March through June. And now we can also conduct virtual trainings. So the goal is to provide adolescent SBIRT training for individuals throughout Connecticut who work with adolescents. What have we achieved so far? We have trained over 1,000 individuals, including nurses, social workers, school counselors, guidance, child guidance center staff. You can see it goes on and on. It's almost everybody from all sectors, faith community, teachers, youth service bureaus, colleges, university staff, states agency staff, and some of the schools that we have trained, and they have hosted the trainings when it was safe. We used to go there and conduct in-person trainings. We can do the same for you if you would like to host our training virtually. We would be happy to conduct that training for you. This is the full training is like 3 and 4 or 4 hour long. This is a condensed version, so I will go over it quickly. But you can, we are conducting virtual trainings at Connecticut Clearinghouse every month. So you can contact us to get more information and to get that full training. So you can see all these school districts listed. Some of the school districts, we have gone there several times to train their, like Hartford Public Schools. We have trained their clinical staff, social workers, guidance counselors, and we will be training their behavioral tracks and support staff in fall. So what the schools have done, they are training all different disciplines, so everybody is on the same page. So this training is for anyone who works with adolescents. So you can see that they have trained all different like nurses, social workers, guidance counselors. So that's one way there have been, the schools are doing the trainings. How else are they implementing Adolescent SBIRT? I think it starts the conversation. Some of the schools like Derby Schools District has implemented SBIRT for a long time, for at least a few years now. So all their incoming ninth grade students, SBIRT is conducted on them. It's a small high school with 200 students, so it's possible to do that. How other schools do that, every school has their own policy. So again, the goal is not that you will go back today and start training, conducting SBIRT, but to go back, you take a look at your policies, what is currently in place, how do you want to implement it, where are the gaps, how do you want to fill those gaps. Okay, just a few reminders that you will receive an evaluation and certificate of attendance within a few days. And then there is a 3-month follow-up survey, which is going to ask you if you have implemented SBIRT. 6-month follow-up survey asking the same questions if you have conducted any screening, brief intervention, referral to treatment. Your email addresses will be added to Adolescent SBIRT listserv. Periodically, we send out pertinent information, articles, trainings. So that is going to be a useful resource. When we do in-person trainings, we hand out participant folders, and these are very robust folders with a lot of information in them. To order these folders and additional handouts, you can contact me. My email address is there. You can call, and we would be happy to mail those folders out to you. Okay. So we're going to go through Adolescent SBIRT. It starts with introduction of adolescent brain. And I've heard that adolescent brain development, brain development was covered by one of the speakers. So we're going to talk about the public health rationale of for delivering the SBIRT services, what SBIRT stands for, and how is it relevant for use in adolescents. So what is SBIRT? It is, and why is government putting so much money into SBIRT? That's because it's a public health approach. It works. It is a public health approach to a public health problem. The more often you ask a question, the more normal it becomes in any setting. And the earlier you start, the earlier you can intervene. Adolescent SBIRT, it's an evidence-based public health approach for identifying and addressing substance use disorder among adolescents in variety of health and social service settings. Like any chronic disease, early detection and early intervention leads to better outcomes. So we are targeting people who are at risk of developing before more severe consequences develop. So you see those two words in red, at risk and before. So think about targeting risky behaviors such as intervening with smokers before lung cancer develops, or with heavy drinkers before liver cirrhosis becomes evident. So, and in medical world, think about blood pressures, any screening, blood pressure screening, cholesterol screening, cancer screening, they all aim at early detection and early intervention to achieve better treatment outcomes. So same is true for substance use disorders. There are 3 delivery components. Screening is conducted to assess the risk of any disease or condition. We use a validated, it's important to use a validated screening tool, administer it appropriately and score it appropriately. If somebody scores positive on that tool, that's when we conduct brief intervention. And brief intervention is conducted with the goal of achieving change in the risky behavior, or if as an early intervention, and if somebody is using at a dangerously higher level, then referral to treatment is the goal. So one thing to note is that the goal is not abstinence here, it's harm reduction. So any decrease in the risky behavior is a step in the right direction. So if the adolescent agrees to drink and not drive, that our goal is achieved. Okay, so we're going to touch that in more detail. So again, broadening the base of treatment, public health approach, focusing on the risk factors versus disease, so we can intervene early and we can have better outcomes. Okay. If you look at this picture, it's showing adolescents and it's showing that they like to take risks. This is a snapshot of substance use amongst our adolescents. And if you can see alcohol is at the top. So that's the most commonly used substance. Third row is marijuana. So that's also heavily used. If you continue going down, you see the pain medications. 3.2% of our adolescents report that they are using pain medications. And the last one is heroin, 0.3. So please note that both pain medications and heroin, they are considered opioids. And when we see what our adolescents are using, they're not using heroin, they're using the pain medications, and right there we see where the problem is. Okay? So the use is risky amongst adolescents. They are not drinking just for pleasure, they are drinking to get to that high. Their brain is wired that way, that they are looking for that highest level of pleasure. So why the brain is developing, so introduction of any substance in developing brain is harmful. There are many risk factors for the use of substances. Genetics is one, trauma is another one. A very important risk factor is the age of first use. So if we can delay the age of first use, that can decrease the risk of developing substance use disorder later on in life. Drinking amongst adolescents, it's not just associated with poor school performance. It's related to other behaviors, other unhealthy behaviors and risky behaviors like drinking and driving, engaging in risky sexual behaviors, using other substances. And it's also associated, the use of alcohol, it's associated with 4 leading causes of death among US teens: unintentional injuries, homicide, suicide, and motor vehicle accidents. The use is undetected, so nobody's asking, or very few health professionals are asking our adolescents the question about their use. And what's going to happen if nobody's asking the question? The adolescents, they're not being linked to services. So if you see the percentage of the health professionals and family practitioners, they're not routinely asking adolescents the question of substance use. And if the adolescent is younger, they're asking even less. And the idea is that, I think the mindset is that the younger an adolescent is, less is the probability that they are using the substance. But people who work in prevention, they know that this is exactly the age when adolescents, they start experimenting. And if nobody is asking them the question, especially their healthcare provider is not asking them the question about their substance use, they're going to think it's not important. If my healthcare provider is not asking the question, it must not be important. Okay. So that was a quick overview of chapter 1. Chapter 2 it talks about why substance use is more dangerous for teens than in adults. So it talks about the adolescent brain development, how different drugs they have effect on brain. And then we are also going to quickly go through the supplement that's developed by Wheeler Clinic about the unique risk factors for girls and their use of opioids. So this is an artistic depiction of adolescent brain, and those of us who work with adolescents, we know that there is some truth to it. You can see what's on their mind. I love the one that says smart mouth, okay? Emotions, sex. And if you look at common sense, it's like very small at the front of the brain. That's the last part to develop. And sometimes when we say what's wrong with our adolescents, why don't they get it? That's because the part of the brain that processes thoughts and judgment, that part is still developing, and that's the last part to develop. Okay. So if you look at the brain development, this slide is showing the synapses. So at birth, there are very few synapses, and brain is like a blank canvas. And as the baby grows, they start learning different things, and all these synapses develop, and this is the stage of blossoming. And you can see the 6 years old, it's like a tangled mess, and now the brain starts to think how to clean this mess. So what happens as our adolescents are aging, the brain is deciding what is it going to keep, what is it going to get rid of. The pathways that are not used, they are pruned away. So this is the stage of pruning. And what is being used, that's left, and that's strengthened with over and over use. So think about it, if substances are introduced at that age of 14 years old, that's when the brain is deciding what it's going to keep, what it's going to get rid of. And if the substances are introduced, those pathways are strengthened with over and over use. So this is a really sensitive age of brain development. Whatever is left behind, it's strengthened with myelination. So this sheath, myelin sheath, grows around the nerve endings, and that makes the messages go more efficiently. This is the last stage of brain development, and it's very hard to reverse. So it's important that brain connections that are formed, they are healthy and they are functional. Brain maturation, again, this is a slide that's showing from age 5 through 20 as the brain is developing. The blue is showing myelination, and blue color is showing that the brain is maturing. So the brain matures from age 5 through 20, and if you note, it is maturing from back to front. So the back matures first, then the sides of the brain, and then the front of the brain where the higher judgment is. So this slide is going to show the same thing a little more in detail. So the part of the brain in the back is cerebellum, and also in the back are occipital lobes, which are responsible for vision. As our toddlers are learning to balance and walk, cerebellum is the first part to develop, and it helps them with physical coordination, and also the occipital lobe, it helps them to visually assess their surroundings. Amygdala is in the temporal lobes on the side. So this is where the emotions are. They are registering what's feeling good to them, what's not feeling good. They are registering all of that. Nucleus accumbens, that's also in the temporal lobes, and that's part of the reward system of the brain. And whatever is going to give them pleasure, they are going to do that activity over and over again, because that has to do with the reward center where dopamine is released. So the last part to develop is the prefrontal cortex, where impulse control and all those higher functions are. And until that part is developed, our adolescents, they put more value on immediate gratification. That's more important to them than, they're not thinking long term. And we also say that they have fully developed gas pedal, but they do not have the brakes yet. We also use the analogy of a house under construction. Our adolescent brain is like a house that is undergoing construction. So think about any storm. It's which house is going to sustain it better. This is showing the reward pathway of the brain, and all the substances, they have effect on the reward pathway of the brain, and they increase dopamine. And dopamine is that happy hormone that tells them, let's do this activity over and over again. We all have some baseline dopamine levels which increase with food, with eating, and with sex. And we also do certain activities when we are depressed. We listen to music, hang out with our friends, exercise. So that increases dopamine level. And the dopamine levels that increase with those kind of activities, they are within the normal range. So if the baseline is 100 or 85, 100 for people who are happy-go-lucky type, 85 for people who see life as glass half full. The dopamine levels go up with these normal activities and they come down. When they come down to the baseline. What happens with these substances is that dopamine levels increase to a very large level. Like with cocaine, they go up to 300, with the heroin anywhere between 500 to 900. So brain is not used to seeing those high levels of dopamine. It's like a shock to the brain. What it will try to do is down-regulate. So its own production of dopamine goes down. So when the dopamine levels come down, in people who use these substances, they do not come down to the baseline of 85 or 100. They really dip down to 40 or 45, which is not enough to motivate anybody to get out of the bed and do anything. So now they use just to feel normal. So this important part of the brain, which is also important for survival, because it's also the survival pathway, that's damaged with the use of alcohol. It's if our kids, they start using these substances early on in their life, later on they feel depressed because now the normal activities are not enough for them that increase the dopamine levels. The age of first use, if we can delay the age of first use, in case of alcohol, you can see if we can delay it from 13 to 21, the risk of developing substance use disorder goes down from 47 to 9. In case of marijuana, it goes down from 17 to, I'm sorry, I can't see the slide. I think it's somewhere around 3%. So you can see that delaying the age of first use, that is very important. Now we are going to go over these substances one by one quickly. Alcohol is a central nervous system depressant. And whereas we say that there is a safe amount that adults can use, there is no safe amount that adolescents can use. So really alcohol use is not recommended for adolescents and for pregnant females. Okay. So this part in the brain, the blue part that you see, this is called hippocampus, and it's for learning and it's for forming memories. Adolescents who drink alcohol, this part of the brain does not develop, it shrinks. And as you can see, this is a brain of a non-drinker and heavy drinker. They're both 15-year-old. They were given a memory function to perform, and you can see that the brain of heavy drinker is not lighting up. 90% of all alcohol consumed by underage drinkers, it occurs in context of binge. And binge drinking is in drinking a lot of alcohol in small amount of time. So for females, it is 4 drinks in 2 hours or less, and for males, it is 5 drinks in 2 hours or less. And if you look at this slide, this is 12th graders reporting binge drinking and extreme binge drinking within the past 30 days. So you can see that the rate, if you look at the first row total, Connecticut rate is higher than the national rate. If you look at the second row, the females, they are binge drinking more than the males. But if you look at the extreme binge drinking, males are binge drinking more than the females. Nicotine, so these days when we talk about nicotine, we are talking about vaping. We are not talking about cigarette smoking. And if you look at this slide, it's showing that the rate of cigarette smoking is going down amongst our adolescents. Look at the 8th graders, 10th graders, 11th graders. It's comparing the cigarette smoking to vaping. So, and this is the daily use. So if you look at that, they're vaping at a higher rate than smoking. And 12th graders, their rate is almost 12%. And what do we know? That most e-cigarettes, they contain nicotine, and this aerosol can harm the body. And even if they say that there's nothing in there, there's no nicotine, that's what our adolescents say, and this is just aerosol, this is just water. Why would you put water? The only thing you want to put in your lungs is clean air. It's not regulated by FDA. They have started regulating the flavors now. So since it's not regulated, it's impossible to know what's in there. And when manufacturers, they started manufacturing these, they came out as cessation devices. But FDA has 6 or 7 cessation devices, and e-cigarettes is not one of them. Flavoring is to target the youth. You also must have heard in the news batteries that have malfunctioned and they have caused burns. And what is happening is that people who start using these devices as a smoking cessation device, they end up, that's what the research is showing, that's what the data is showing, that they end up using both e-cigarettes and cigarettes. So this is how an e-cigarette looks like. There's a battery that heats up the cartridge, and the cartridge has the fluid that contains nicotine. There are some cartridges that adolescents, they are able to fill themselves, and they are vaping marijuana with that, with THC with that. Vapor is created, it comes out, and again, it's not vapor, it's aerosol that they inhale. Also, as this fluid is heated up, there are some heavy metals that are released, which also the adolescents, they end up inhaling those as well, which is all dangerous to lung. Marijuana, we know what's the dangerous, the psychoactive substance, THC. We worry about that, that's the dangerous substance. And if you look at the daily marijuana use, that's going up amongst our adolescents, and the gap is closing between the 8th graders and the 10th graders. These are all the pink dots that you're seeing. These are all the receptors where the THC goes and attaches itself. And as you can see that there are many THC receptors in the frontal cortex, so it affects the judgment. In cerebellum towards the back, you can see there are many pink dots, and that's the balance is affected. In the center where the pink dots are, that's where the reward center of the brain is, reward pathway of the brain is. So it's priming the brain for addiction. That there's also has the hippocampus that forms memory, hypothalamus that controls regulates the temperature, appetite. So you can see how it's affecting all parts of the brain. The one part of the brain that does not have these receptors is the brain stem close to the cerebellum in the back. You can see there are no pink dots there. So that's where the respiratory center is, because there are no cannabinoid receptors there. There is no overdosing with marijuana. And you can see that with time, THC level is going up in marijuana, and as the THC level increases, so does all the harmful effects like anxiety, paranoia, hallucinations. Okay. And regular marijuana use during adolescence is found to increase risk 2 to 5 times of developing psychosis, schizophrenia, anxiety, and depression in adulthood. Okay. Prescription drugs, and they come naturally as opiates and then synthetically as opioids. And we have heard about Vicodin and Oxycontin, all those misuse of all those prescription medications. So there is a place for opioids. If somebody has gone through surgery, they have been injured, they're given opioids to control pain, and there are receptors in the spinal cord that control pain. But if somebody they do not need it for the injury or to control pain for any reason, they just take it to get high, then what happens is that marijuana goes and attaches itself to the receptors in the prefrontal cortex, and it impairs all the higher functions like judgment and impulse control. In the center of the brain where the limbic system is, this is the area that's responsible for development of addiction. So that's priming the brain for addiction. And if somebody takes high doses of opioids, there are receptors in the brainstem. In the brainstem is where the respiratory center is. And opioids, they are a CNS depressant. They depress the respiration rate goes down, and eventually people just stop breathing, and that's how overdose happens. Okay. What are the reasons for misusing opioids? So you can see anything in blue is easy access. It's easy to get from medicine cabinet. Anything in red, it's safer to use. So that's perception of harm is low. They think it's safe because a doctor prescribed it. And then anything in gray is there are no legal consequences if you're caught with it. And a lot of the people, if you ask people who use heroin, they'll tell you that most of them started with prescription drugs, and then they ended up using heroin when their supply ran out. Prescription stimulants, they're used for if somebody has ADHD, then they have a place. But again, if they are misused, what happens is that they act like cocaine. So there's a sending neuron sending dopamine. Receiving neuron has receptors for dopamine. Dopamine sits on those receptors and it exerts its effect. Whatever is left behind, the red balls within the synapse, it's taken back, it's transported back by transporters to the sending neuron. So that's how that balance is maintained. If somebody is misusing prescription stimulants or they're taking cocaine, these transporters are blocked and dopamine cannot go back to the sending neuron, it stays within the synapse. So adolescent girls and opioids, we are going to cover that, which is again a supplement developed by Wheeler Clinic. So if you look at the national data, 2.8% of our adolescents report using opioids and 0.1% use heroin. So again, 2.7 are using prescription medications and only 0.1 are using heroin. So non-medical use of prescription drugs, so they are not using it as prescribed. If you look at Connecticut data, nationally the rate is 14%. Our rate is 11.2 to 13.6%, and it does not vary by gender. Heroin use, our rate is a little bit more than the national rate, which is 1.7, ours is 1.8, and males are using it more compared to females. These are the different risk factors for use amongst adolescent girls: trauma, biological, mental, social influences, transitions. So girls and women, they have increased likelihood of experiencing any kind of trauma. And there is a close relationship. So if somebody is using substances and they have an underlying trauma, unless the underlying trauma is addressed, it's treated, substance use is not going to go away. Sexual physical abuse, again, our females, our adolescent girls, they experience that more. And sexually abused girls, they use substances earlier, more often, and in greater quantities. Intimate partner violence also leads to the use of substances, and older partners, they introduce girls to opioids. Household trauma, so if they are seeing overdose in the house, substance use in the house, they are more prone to use substances themselves. And research shows that if the mother is alcoholic, the girls also tend to start using substances and become alcoholic. Trauma and stigma, so if you ask boys, they're very open about their substance use, but the girls, they experience stigma. And if they are pregnant, then stigma is even more. If there's an LBGT issue, you throw that in there, there's even more stigma. And what does stigma do? It does not, the girls are not going to tell us about their substance use, and that prevents them to be linked to the services. All other forms of trauma are listed here: trafficking, sexism, sexual harassment, racism, discrimination, parental separation, divorce, involvement with criminal justice system, any kind of disability, cognitive or physical. It's important to note that all these risk factors that have to do with the ACEs study, they increase the risk of substance use. The girls are resilient, they can recover. You might know about the 40 developmental assets by Search Institute. These are all the protective factors, and more protective factors adolescents have growing up, less is the risk of developing the substance use disorder. There are some externals, there are some internal factors that are listed under 40 developmental assets. Some of them are like your connection. Do you feel connected to school? Do you have one trusted adult in your life? So those kind of things, you can look that up. Okay. Brain maturation, again, if adolescent brains they're developing, if you introduce substances there, it's not good for developing brain. Adolescents that are prescribed opioid by 12th grade, they are 33% more likely to misuse prescription opioids by the age of 23. Puberty, early puberty also puts girls at the risk of using substances because they might not be ready mentally, and this might be a stress for them. And also they associate themselves with older adults, older teens, older boyfriends, and that's how that's putting them at risk of substance use. Female life cycles, so if they have menstrual pain, they're using opioids to take care of that. Okay. Girls are more vulnerable to physical impacts of substance use and addiction, so low levels can cause serious health consequences for girls. Telescoping is a phenomena which is unique to females, unique to girls, that from initiation to addiction, their pathway is short. So they progress very quickly from first use to addiction. That's why it's important to ask them to screen them for substance use, and that might be due to the body differences in the body fat percentages, metabolic rate, hormonal fluctuation. Okay. Mental health disorders also put them at the risk, and many teens with mental health disorders turn to alcohol and other drugs to self-medicate. Girls experience more depression and anxiety compared to boys, and sometimes our teens, our adolescent girls, they are using to be part of a certain social circle. Any form of transition from middle school to high school to college, moving from one neighborhood to another, this all is a stress for adolescents, and they start using to combat loneliness, to mentally check out. So opioids are not only taking care of the physical pain, they're also taking care of the emotional pain. They are numbing them, so they are using it for that reason. They also use it to look cool or change their image, to fit in. They also use this to fit in a desired group of friends, because peers and friends, they are very important to adolescents. These are all the resources from where this information is coming. Okay, screening, that brings us to screening. So there are certain screening tools. If you order these, if you request these folders from us, these will all come. This is a booklet. It's the same screening tool in a booklet form. This is a handout. So you can all get that by contacting us. So we are going to discuss how to use the screening tool. So just to let you know, this is not in any way diagnostic. It is to assess the risk and to assess what the next steps would be. Okay. So just by looking at someone, we cannot tell if they are using or not. So every adolescent is at risk, so every adolescent should be asked the question. Okay. So SBIRT is a quick way of screening. It's for short, it's practical for short visits, and it's 90 to 100% accurate. If you look at this cone, it's developed by American Academy of Pediatrics, and if you start looking from the base, when you are going to ask adolescents about their substance use, a lot of them are going to tell you they don't use substances. Look at the second one, the one in blue. There will be a good portion of adolescents will tell them they used it once or twice in the last year, and so they are experimenting. So adolescents who are not using, or who have used it once or twice in the past year, they are not at the risk of developing substance use disorders. The next one is mild to moderate. So that's our yellow area in that cone. And these are the adolescents who are using at monthly levels, and that puts them at the risk of mild to moderate substance use disorder. At the very tip are the adolescents who are using weekly, and that can put them at the risk of severe substance use disorder. Okay? So how to start the conversation? It's not easy to ask adolescents about the substance use. This is just giving you a script, and you can use your own words, but there are certain components in it, and it's important to include those. In order to help you get correct services, I would like to ask you some questions about your health that I ask all of my clients and patients. Or students, these questions will help me to get to know you and provide you with the services you need. Is that okay? So 2 things are important here. Letting them know that you're asking these questions from all the students, and asking their permission. Is that okay? So these 2 components are important, and then you can ask it in any way you like. You can use your own words. Confidentiality, bringing that up front. That's very important. That research has shown that if you bring it up, let them know about it up front, then that elicits honest responses, letting them know that whatever you say about your substance use, it's going to stay between you and me, unless there is a risk of harm to you or to others. It's always good to include parents. Try to include parents because there is better treatment outcomes if parents are involved, because who is going to bring them to visits and follow-ups? Okay. So this is the screening tool. It has the first part has questions about tobacco, alcohol, and marijuana. And now we have included opioids in that part as well. And the idea is that if you ask them the question about their tobacco, alcohol, marijuana, and opioid use, and they say no to it, then it's the chances that they are using any other substances, they are very slim. So if you look at the responses, never, once or twice, monthly, weekly, or more, they correspond to that cone that you saw. So you have to ask, with the screening tool, it's very important to ask the question the way it's written. You cannot reword it and say, you don't use drugs, do you? So that does not elicit the response, the correct response. So questions have to be asked every time the way they are written. So in the past year, how many times have you used tobacco? Never, once or twice, monthly, weekly, or more. In the past, how many times have you used alcohol? Never, once or twice, monthly, weekly, or more. In the past year, how many times have you used marijuana? Never, once or twice, monthly, weekly, or more. So every time with every substance, giving them the 4 choices and asking the question as it is written. Okay, so since prescription drug use is a serious concern, the rate of use is rising at higher rate, please include 4th question of S2BI. So this question about prescription drug use that is under part 2, we are recommending that you start asking that as a part 1 question, along with tobacco, marijuana, and alcohol use. The important thing is that with prescription drugs, you have to ask them about their own prescription drugs, or prescription drugs they have acquired from someplace else. So in the past year, how many times have you used prescription drugs that were not prescribed to you? Never, once or twice, weekly, or more, or use drugs that were prescribed to you in ways other than as prescribed. So you are not using them as they were prescribed to you. Okay. So the other thing I want to bring your attention to is that within the folders that we have also developed this S2BI response card. It has common names of all the substances. So our adolescents, they're more familiar with some substances like for inhalants, for example, it's asking about nitrous oxide. They might not know what nitrous oxide is. But if you look at this handout, it has inhalants and then the common names given as laughing gas, poppers, rush, and they will know what it means then. Okay. So screening process, we just did that. Okay, so if they are not using the substance in the past year, so we are going from left to right, so green to red, no substance use in the past year or substance use once or twice in the past year, it tells you what to do. So if there is no use, you provide them positive reinforcement. If there is, they have used it once or twice in the past, you provide brief advice. And if you look towards the bottom, under both these categories, they are not at the risk of developing substance use disorder. Orange, they are using monthly, you provide brief intervention, and they are at the risk of mild to moderate substance use disorder. Red is weekly use with brief intervention. Now they need to be referred to treatment. They're at the risk of severe substance use disorder. So this SBIRT, it corresponds with DSM-5 substance use disorders. Okay, we're just quickly going to go through the scenario. Actually, we don't have time. We'll try to do one. Okay. The 14-year-old girl presented to you for annual physical. You ask the screening questions. She says no to tobacco, alcohol, marijuana. And what do? Provide positive feedback. How do you do that? It's a great decision to avoid tobacco, alcohol, and other drugs. Most kids your age don't use them. It's one of the best ways to protect your health. Keep it up, and I want you to know that you can always ask me any questions you may have about them. Important thing to note, do the norms correction. Most kids your age don't use them. Okay? They think most kids are using. So this is the norms correction. Most kids are not using. It's just your little group of friends that are using. The last sentence, I want you to know that you can always ask me any questions. So that keeps the door of communication open. Down the road, if they have any questions, they can always come back to you because you were one adult that took the time to ask that question. Okay, so there's another scenario. Marcus is a football player, and when you conduct the screening, he's telling you that he has used marijuana once or twice. So in your screening tool, if you remember, once or twice use was falling under the yellow. So once he says once or twice, you ask him the rest of the questions because he might be using some other substances. He said no to everything. So now you provide him brief advice. Okay, I would recommend for the sake of your health that you stop smoking marijuana altogether. Heavy marijuana use can affect your concentration. Over time, it can impact your mood and affect your performance on football team. You're such a good athlete. I would hate to see anything get in the way of your future. Okay? So again, this is another example. Monique, she's a freshman. Her parents have been recently divorced. She and her sister have been verbally sexually abused. She's seen the school nurse several times for severe menstrual pain. So what are her risk factors? Adolescent girls transitioning to high school, trauma history, experiencing menstrual pain, grades are dropping. You conduct the screen and you find out that she's using prescription drugs weekly or more. So what are you going to do? Okay. So now you have to provide brief intervention, and that's coming up. So what are you going to tell her? I'm very concerned about your regular use of prescription drugs. Adolescent girls like you are at increased risk for misuse and addiction to opioids. I advise you to quit, and I would like to refer you to a very special program for teens who are using opioids called Project Assert. I'm confident it will help you. How do you feel about that? Okay. So the motivational interviewing, we need this skill in order to conduct brief intervention if adolescents, they are using using monthly or weekly. And motivational interviewing, it's basically conducting brief intervention using open-ended questions, using affirmations, reflective listening, summarizing thoughts. So OARS, you have to remember this acronym, OARS. And some of you might already be doing it, asking open-ended questions. This is a therapeutic treatment strategy that was originally developed for substance use disorders, but now it can be applied to anything, any health lifestyle behavior. So basically, it's you're talking to adolescents. It's an interaction where you are trying to motivate them to change their behavior. And you're not telling them to stop using, you are motivating them. It's coming from them. It has to be intrinsic. Okay? You have to respect, again, being non-judgmental, whatever they decide to do. You might not agree with that, but respecting their decision. You're not conducting, it's a collaborative approach. You do not conduct MI on somebody, you do it with them. And you're eliciting their own reasons for change. You're not the expert, they are their own experts. They know what they can do, and they have their own strengths. And if it's an intrinsic reason versus, us forcing something upon them, it's going to be more long lasting. Expressing empathy is important. Rolling with resistance, again, that's normal. If you're going to confront them directly, they are going to become more defensive and they're not going to change. So just change your, just roll with resistance. Supporting self-efficacy, letting them know they can do it, they have strengths. Recognizing and working with ambivalence. Ambivalence is having conflicting feelings about something. They are liking it and not liking it at the same time. So helping them figure that out and making use of feedback. So stages of change, when we see adolescents, they are not all ready. They're at all different stages. Pre-contemplation, they are happy users, not thinking about change. Contemplation, that's the stage of ambivalence. They are not liking it, not liking it at the same time. To preparation, to action, to maintenance, and sometimes they relapse. Our goal is that whichever stage they are at, we help them move to the next stage and also provide an intervention that is appropriate to that stage. Again, OARS, asking open-ended question, tell me about your marijuana use. So this is an example of how to change close-ended to an open-ended question. Tell me, what is it that brings you here today? That's an example of an open-ended question that's going to give you some more information. Affirmations, everybody likes them, and they have to be genuine. Reflective listening, it demonstrates that you have been listening to them, and it's also a way of checking rather than assuming. So you say something and they say, this is not what I meant. So this is an opportunity to correct yourself. This is some ways of saying what I think I hear you saying. Summarizing on one hand and on the other hand. So this is letting them know that their goals are not matching with their behavior. Whatever they said, you're summarizing it and presenting it to them. On one hand, you said this, and on the other hand, never use the word but, because then it becomes judgmental. And looking at for the change talk, if you see they're saying anything negative about the substance use, that's the step in the right direction. Readiness ruler, you're asking them on scale of 1 to 10 how ready they are to make a change, how important the change is to them, how confident they are that they can make the change. And if they give you a number, say 4, I always ask, why didn't you choose a lower number and how can we make it go higher? Never ask, why didn't you choose a higher number? It's not good for their confidence and it's going to elicit negative talk. Developing discrepancy, what is it that you like about the use? What is it that you don't like about the use? And always remembering to be non-judgmental. So these are some of the videos that you can watch to build the skills again. When you request the materials, you can get this information. Brief intervention, we have this tool that you can use for brief intervention. It has all the steps listed and it makes things go very quickly. It provides guideline. So step 1 is building rapport. And I am aware that we have 5 minutes left. So few minutes left, okay, 7 minutes. So building rapport, so engaging the adolescent, assessing problems, exploring values, and asking craft questions. Craft questions are, they basically assess the risk with the screening tool, the S2BI screening tool, screening to brief intervention that we use, that assess the frequency of use. Craft is, it assesses the risky behavior. Have they driven in a car? Do they use substances to relax? Are they using it alone? Do they forget things? Is their family or friends telling them that they should cut down? Are they experiencing any trouble? Step 2 is pros and cons. What is it that you like about the use? What is it that you don't like it? And summarizing it, again, using the word and avoiding the word but to remain non-judgmental. At step 3, you ask their permission to provide feedback. I have some information about your marijuana use. Is it okay if I tell you about it? And always advise them that my advice for you is to stop using. But however, the decision to quit is really up to you. What are your thoughts about it? And at that point, whatever they say, they're willing to cut down, whatever whatever risk reduction behavior they can tell you, you can work with them. Let them come up with the options. Also educate them what a standard drink is. Readiness ruler, we covered them, how ready they are. Having an action plan is important, developing an action plan with them. What are some of the options? What can you do? What have you done in the past that you were successful? What are your supports? What are the challenges? How do you envision future? Affirming the ideas, writing down the action plan, giving referrals. If they are using at a higher level, they might need referral. Giving them the action plan, thanking them, setting up a follow-up appointment. And if they need to be referred to the treatment, it's important to know what treatment options you have in your community. So knowing your community resources is important. And also at that time, you have to let others know. You have to break confidentiality, involve parents. Sometimes when you are asking them questions, screening them for substance use, some red flags come up. And now you need to have a safety plan in place. So emergency department visits, IV drug use, mixing sedatives, using alcohol in large quantities, less than 14 years of age, driving after use, nearly daily use, alcohol-related blackouts, polysubstance use. These are all red flags, and now you need to assess them for homicidal, suicidal ideation, involve parents and other adults, expedite urgent evaluation, contract for safety, and monitor them. So we don't have the time to view this simple scenario. Again, want to let you know that we are offering monthly, longer 3 to 4 hour virtual trainings at Connecticut Clearinghouse, and you can contact us for those trainings. Referral to treatment, again, knowing the resources in your own area. And again, if you remember that cone, very small number of adolescents need to be referred for treatment. Determining the level of care. What is the patient and parent preference? Is there any co-occurring mental disorder? What's the program availability? What's the insurance coverage? Treatment type, don't mix them with adults. They should be referred to adolescent-only programs. These are all the treatment options. Individual counseling. Group programs, they haven't been well studied. There are some pros and some cons. There's limited availability, not well studied. Pros are they're cost effective. It allows for peer support, family therapy, intensive outpatient therapy. These are all different programs. Recovery High School, there is none in Connecticut, alcohol acute. So these are all different programs that are available, and it tells you the length of stay and what's covered in them. Medication-assisted treatment, it is endorsed by American Academy of Pediatrics. So if adolescents, they need it, medication-assisted treatment for opioid use, they should be given that. Okay, Connecticut Resources, Beacon Health Options, 211, Infoline, Connecticut Network of Care. CROSS, it's a support program, recovery program. It offers peer groups. And if you, again, get these materials from us, we have a list of all the support groups that are happening throughout the state with the contact information, timings, everything. You can get that information from us. Project Assert, it employs MDFT, MET recovery support, and it is for actually youth until the age of 21. So again, we have information about that. There are 3 or 4 funded entities. There are 4 funded entities. So we have contact information, who to contact, who to call. Again, we can send these handouts to you, send this information to you. Okay. Reassess after treatment, help to monitor upon return to school. That can be your role. Again, these are the resources. Again, reminders, what's going to happen next. You will be receiving evaluations and certificates of attendance. You will be receiving a 3-month follow-up survey, a 6-month follow-up survey. Your email addresses will be added to a listserv, and where you might get periodic emails and that will have pertinent information. My contact information is there if you would like to get the folders, the handouts, and if you would like to attend a longer training, or if you would want us to conduct a training for your school, for your organization, we would be happy to do that. Okay, and that's the end. Are there any questions?
We do have a question in the chat. Latanya, can you unmute your mic and ask your question?
Hi, Aisha, thank you so much for a very thorough presentation. And so the question I'm posing is in terms of, you always think about substance misuse, are there possible on-ramps? So as a result of the pandemic, there's been a notable increase in anxiety and trauma in some of our communities around the state. And so in conversation with some parents in my local community, they've disclosed that their children are starting to become dependent on daily substances over the counter for calming and sleeping aids. And so in terms of, one parent shared with me, her daughter is very dependent on melatonin to go to sleep, and she refuses to go to sleep without it. Is that something that we should also be vigilant in terms of dependency on substances and how that might possibly down the road lead to other substance use and misuse?
Sure, that's a very valid question. This pandemic that is increasing anxiety levels and depression levels, not only amongst adolescents, amongst all of us. And introducing our kids to healthy ways to deal with that stress, with that anxiety, with that depression, that should be our goal as parents, as educators, as responsible community members, keeping an eye out, and again, building those protective factors. What can we do? What alternatives can we offer? There are many, there are mindfulness techniques. There are many other things, exercising. What can we do together as a family, as a community? And any of use of any of those substances might lead to, they are at risk of using other substances. Again, that's a very valid question. And it's also a thought for us, what can we do as a community, and what are going to be our action steps?
Thank you very much.
Any other questions? I don't see any in the chat. This was an amazing presentation. Thank you so much for all of this valuable information, and really hearing how we can support girls. I think that has really been eye-opening to me. So thank you again.
Thank you for having me.
And we wish all of you well. Hopefully you can check into the next breakout session that we're going to have.
Have a very nice day, everyone.
All right, take care.
You too.
Be safe. Okay, so Lauren, I'm going to leave. You can end the recording.
Okay.
All right, take care.